Okay, hello everyone, and welcome to session 2 of the April Grand Rounds. I'm going to turn this over to Dr. Brett Wyrick, the Deputy Federal Air Surgeon, to get us started. Dr. Wyrick, would you like to say a few words?
Thank you, Christy. And I'd like to say good evening, good afternoon, good morning, and good night to everybody. It looks like we've got quite the crowd here tonight and some real heavy hitters in the world of aerospace medicine. I want to give greetings to all my Air Force and Guard colleagues out there. It's great to see all of you. And we've got a really good Grand Rounds tonight. Dr. Samantha King is going to be presenting and going to give you some of the updates that we've been working on here in the Office of Aerospace Medicine. And I want to thank all of you for being here, and I want to thank you for your interest in aviation safety and participating with us as aviation medical examiners. Christy, back over to you.
Thank you, Dr. Wyrick. As always, we have just a few housekeeping items to go over before we jump into the content of the session. First and foremost, this session is being recorded and no participants will be shown. The recording will be made available at a later time on our YouTube channel. We did have one comment at the earlier session today that the March Grand Rounds is not located or not loaded yet on the YouTube channel. And we are aware of that. We've done some checking. It should be there soon. To find those past recordings, all you need to do is open up a browser window, find your search bar and type in FAA AME Grand Rounds, and you should be able to go to our playlist that way. Next slide, please. The rules of engagement for the session are first up, we will lock the session after the first 10 minutes or so. We do grant 1 hour of free CME each month. And because of that, since it's only 1 hour, we do lock the session after the first 10 minutes or once we've started into the content of the lesson. What this means to you is that if you drop out of Zoom, let's say you're having technical difficulties or you're having whatever, for whatever reason, you may not be able to get back into the room. You can try sending an email to the AME notifications email, and Linda just dropped that in the chat. So you might want to copy that or jot that down. And we do have one person able to monitor that this evening. And if they see your email, they may be able to reopen that and let you back in. Your chat, your cameras, those are disabled. We want to capture your questions using the Q&A button at the bottom of the screen. So if it's been a while since you have been in Zoom or you're not familiar with Zoom at all, take a look at your screen, look towards the bottom. You may have to move your mouse a little bit or move your finger around on your screen and find that Q&A button. That is where you're going to enter in any questions you may have. We would ask you to limit your questions to the topics being discussed. That will allow us to answer your questions in a timely manner throughout the session. Also, as part of our accreditation, we do have to disclose if there are any prohibited relationships that need to be disclosed ahead of time. This is the statement for this session that no speakers have any prohibited relationships to disclose. Next slide, please. For free CME, you must have your full first and last name displayed in Zoom throughout the entire session. So if you would take a look at your screen, find your name either under the participants link, there's a button there for participants, or find your little square and look at the top of the corner there and see that your name is displayed. We cannot give credit for office staff or iPhone or iPad or phone number or anything like that. You do have to have your full first and last name displayed. Also, for our FAA employees only, please ensure that FAA is at the end of your Zoom name. For the rest of you, for our AMEs, we do appreciate that you are an FAA AME, but please do not add FAA to your username unless you are actually an employee. Also, if you're watching this in the future and you're watching the recording, keep in mind that we are unable to give CME for watching the recording. However, we do appreciate the time that you spend attending the sessions and watching the past recordings. Next slide, please. Our session today is going to be over the AME guide updates that were released today. We have some new disposition tables for eosinophilic esophagitis, as well as a new CACI for that. We have a new disposition table for hormone replacement therapy for females. We have updated requirements for carotid stenosis, restore some content to the protocol for multifocal contacts. Next slide, please. As well as made some updates and simplified information for typical A flutter, the NASH, prediabetes and weight loss management, low testosterone or low T, colitis, and arthritis. We've also made some medication updates that were released today. We have 2 new medication pages, one for smoking cessation and one for osteoporosis, as well as some updates to biologics and HIV PrEP. And with that, I'm going to turn this over to one of our medical officers, Dr. Samantha King. Dr. King.
Thank you, Christy. Hello, everyone. As Christy mentioned, we have quite a few topics to get into tonight, so we're going to go ahead and dive right in. The first is a new condition. This is eosinophilic esophagitis. For those who may not be familiar with this condition, it is a chronic immune-mediated disease where eosinophils build up in the esophagus, ultimately resulting in chronic inflammation, dysfunction, and damage. The biggest concern for individuals with eosinophilic esophagitis is the risk for food impaction, which if one were to have while in flight could be suddenly incapacitating. So you'll see here that there is a new disposition table over on the right, as well as a new CACI. In the disposition table, you'll see at the top the row for individuals who are considered in clinical and histologic remission with potential for CACI issuance. Individuals who've had a history of food impaction within the last year are still symptomatic or considered not adequately treated, or individuals with fibrostenotic disease, as well as those who do not meet the CACI criteria, would be a defer. You can see here in the table the various information that we would like you to submit for the FAA to review. Now, for that CACI table or that CACI worksheet, you'll see here the individual needs to have a treating physician deem that they are both compliant as well as stable with no side effects, documentation of the most recent endoscopy within a time frame that has been recommended by their treating gastroenterologist for surveillance. And that endoscopy needs to show that the disease is considered in histologic remission, as well as have no evidence of fibrostenotic disease. This can be from esophageal rings, strictures, or a narrow caliber esophagus. These are all things that would put an individual at higher risk for having a food impaction. The individual also needs to have not had a food impaction in the past 12 months or while on treatment. Treatment with 3 classes of medications would be deemed acceptable, including proton pump inhibitors, topical or oral steroids that do not exceed the 20 milligram prednisone dose per day, as well as the monoclonal antibody dupilumab, otherwise known as Dupixent. And just a reminder for that last one, it does have a 4-hour post-dose observation period. Now, if an individual meets all of these criteria, they would be considered CACI qualified. Please document that in Block 60, and if they are otherwise qualified, may go ahead and issue. The next update is a new disposition table for hormone replacement therapy for females. This is a disposition table that has both an issue row and a defer row. You'll see for individuals on hormone replacement therapy, estrogen, progesterone, testosterone, near physiologic levels. If you can determine that there's no side effects that could potentially interfere with their duties, no history of blood clots, and no history or increased risk of stroke, severe migraine, or uncontrolled hypertension, you may go ahead and summarize the information in Block 60 and issue. However, if the individual does not meet these criteria or has a history of blood clots or stroke, you'll need to defer. For individuals on the hormone replacement therapy, you'll need to submit a detailed clinical progress note, including a history of hypercoagulable conditions, blood clots, or stroke, as well as the information needed for VTE or stroke should they also have that condition. Now, for carotid stenosis, you'll note on the disposition table that there are 3 rows. Row A, which is for individuals with disease of 49% or less with no history of TIA or stroke. Row B, for those individuals with a stenosis percentage of 50 to 79%, again with no history of TIA or stroke and not recommended to be on anticoagulation or to have surgery. There are no changes to either of these rows. However, for individuals that have stenosis of 80% or higher, are taking anticoagulation, or for which surgery has been recommended, there is an update to the requirements that we are asking to be submitted to the FAA for review. There's no longer a requirement for an ultrasound. However, the airman will need to have had a CTA, MRA, or angiogram of the head and neck performed within no more than 90 days of the AME exam, as well as a current brain MRI. Now, the disposition has not changed. These individuals will still need to be deferred to the FAA for consideration for special issuance, but it's just a change of the imaging that is required to be submitted as part of that review. Next, we would first like to thank the AME that caught this and let us know by submitting that to the AME guide box that we had an inadvertent removal from this page. And so this is not a new protocol or new information, but rather restoring information that was previously there. So for individuals who have bifocal or multifocal contact lenses, we do require a 1-month adaptation period for them to adjust to those lenses. This is not, again, content change, but was inadvertently removed in 2025. Otherwise, the vision standards remain unchanged. For typical atrial flutter, there is a clarification we are making to the information in row B. So row B deals with individuals with typical atrial flutter that have been treated with ablation within the last 2 years, or that are currently being treated with antiarrhythmic medication. We require a 24-hour cardiac monitor to be performed at least 90 days after the procedure if they've been ablated. So for an airman who has been treated in the last 2 years, it doesn't necessarily need to be within 90 days of the AME exam, so long as it is at least 90 days after the ablation procedure. So someone who had an ablation 18 months ago and then had a cardiac monitor 6 months ago could come into your office and use that cardiac monitor in order to submit for consideration. An additional cardiac monitor does not need to be performed. For MASH-NASH, we have an update to the CACI as well as the disposition table, and this is a change to the threshold of the FIB-4 index. On the disposition table here, you'll see that for anyone with a FIB-4 index now of 2.68 or higher, the disposition would be defer. In addition to this, the individual has undergone any imaging studies for their MASH or NASH, such as an ultrasound VCTE or an MRE that should be submitted as well. And then lastly, we have a typographical update that physical exam findings are required to be documented, not ophthalmologic exam findings. Along with that, the CACI worksheet has been updated to also match that level. The FIB-4 index less than 2.68 is the new threshold. And so an individual who has only had lab work done may only be able to calculate a FIB-4 index. And if that is less than 2.68, they'd be considered CACI qualified. Now, if an individual has also had ultrasound or magnetic resonance elastography performed, you should cross-reference the fibrosis score from those tests to ensure that they are also below these thresholds. So an individual should not have any values that exceed the limits here. However, imaging is not a requirement to be CACI qualified. If they've only had labs and it is less than the FIB-4 index score of 2.68, they would be considered CACI qualified. We additionally have updates to the pre-diabetes worksheet as well as the weight loss management worksheet. And that is here we've reduced the time after a dose or drug change. So an individual who is starting on a weight loss or pre-diabetes medication that is considered qualified underneath this worksheet, they only need to wait 48 hours after having a dose increase, medication, or formulation change. They do still need to have a 2-week initial observation period after they start the medication for the first time, but as they increase or ramp up their dose, it is now a 48-hour observation period instead of 72. This is for both pills as well as for shots. This is additionally reflected on the weight loss management worksheet, again noting that reduction of time after a dose or drug change from 72 hours to 48 hours. And this is a change specifically for weight loss and for prediabetes, and is not necessarily the same change for those individuals being treated for diabetes. In addition to this, on the weight loss management worksheet, we are no longer requiring an A1C. So if an individual is utilizing these medications for just weight loss, the A1C is not required. However, you'll note at the top of both of these worksheets, if an applicant has ever had an A1C of 6.5 or greater, they would not be considered CACI qualified. Those individuals would need to follow the diabetes pathways. And then for individuals who have an A1C of 5.7 to 6.4, that'd be considered for prediabetes, and they should refer to that page. These changes are additionally noted on the worksheet as it is one status report for both weight loss management and prediabetes. And so you'll see here highlighted that an A1C is only required for prediabetes to be current within 90 days of the AME exam. And if the individual is utilizing the medication for weight loss and not for prediabetes, the provider can simply write NA in that medication box and continue to fill out the rest of the status report. The remainder of the CACIs and the remainder of the status reports are unchanged. It is just these timing as well as A1C requirements that have been updated. For the low T or low testosterone CACI, we have expanded to include an additional medication of tamoxifen. And so this has been updated in the disposition table, as you can see here. It has been also updated on the status summary report down here in the current acceptable medication list. The remainder of the status summary is otherwise unchanged, and the previous other requirements are also unchanged. And then lastly, in the CACI table, you'll see here tamoxifen added to the bottom underneath the medication list, as well as a hyperlink to that status summary to try and help make it easier for individuals to locate. We've additionally expanded the medications acceptable for the CACI for colitis. We have 2 monoclonal antibodies that have been added, guselkumab, also known as Tremfya, as well as risankizumab, known as Skyrizi, are both acceptable medications to be CACI qualified for colitis. The remainder of their medications are otherwise unchanged. We've also updated some of the medication information in the arthritis disposition table for individuals with osteoarthritis that is well controlled with no limitations that are treated with daily NSAIDs. Those individuals would now meet row A criteria with the disposition of issue, summarize the findings in block 60. They are no longer need to follow the CACI worksheet. For individuals who are on more medications than just NSAIDs, they would need to follow the CACI criteria, but those medications can be utilized in addition to daily NSAIDs and still be CACI qualified. And so to clarify, this is what the worksheet will now look like. You can see here under acceptable medications that an individual may use one or more of the following with or without daily NSAIDs. Again, the remainder of the medication remains unchanged. They can use one or more, a combination of the below medications, with the exception of a singular biologic, as you'll note at the bottom. Speaking of biologics, there has been some clarification that we have made to the biologic medications table. As you'll see here, it is listed as conditionally acceptable, which means that the condition for being able to issue is going to be dependent upon the underlying condition. Some of these medications, an individual may be CACI qualified. You'll recognize under the interleukin inhibitors, the dupilumab, which is CACI qualified for eosinophilic esophagitis. However, it will be dependent upon the underlying condition for which the individual is utilizing the biologic medication. Depending on the condition, some individuals may still need to defer and submit information to the FAA for review. And lastly, just a reminder that these are utilized in monotherapy to be considered CACI or conditionally qualified, depending on the underlying condition. We also have expanded the allowed medications for HIV PrEP. You'll see here in the first row that we have added Yeztugo or Lenacapavir. This is an additional medication, again, that can be utilized for HIV pre-exposure prophylaxis, otherwise known as PrEP. If individuals are utilizing these medications for HIV or for age, they'll need to follow the HIV protocols. However, as a reminder, if the individual is using any of the approved medications, they may go ahead and be issued if they otherwise are qualified. We have, as mentioned, 2 new pharmacy pages, the first of which is for osteoporosis. You'll see here the list of acceptable as well as unacceptable osteoporosis medications. You'll note that the initial observation and post-dose observation varies depending upon the class of medication. Oral bisphosphonates have no initial or post-dose observation, but as you get down to things like the sclerostin inhibitors or monoclonal antibody, romosozumab, it has a 2-week initial observation and 4-hour post-dose observation. And so this will be dependent upon the class of medication of which the airman may be using. And again, as a reiterance, this is guidance for osteoporosis treatment only. If an individual is utilizing these medications for a cancer-related condition or other related condition, that may have an additional observation period and/or other requirements beyond just the initial observation and post-dose observation time. And then additionally, there's an unacceptable osteoporosis medication at this time that would otherwise require review, and that would be interferon gamma 1B. The other new pharmacy page that we are adding is for smoking cessation. You'll see at the top the list of acceptable smoking cessation medications, including nicotine replacement medications, as well as varenicline, otherwise known as Chantix. You'll also notice again the initial observation ground trial and post-dose observation no-fly times for each of those. And then for the oral medication Chantix, the AME also needs to confirm that there's no history of psychiatric conditions or concerns. If there are, please follow the anxiety, depression, and related conditions table. You'll also see here the list of unacceptable smoking cessation medications, including bupropion and nortriptyline. If an individual has received a treatment course of bupropion for smoking cessation and then has stopped that medication, you cannot issue during active treatment, but once treatment is complete, a 7-day no-fly after the last dose is required. For individuals who use bupropion either for recurrent treatment or extended therapy for more than 6 months, should follow the anxiety, depression, and related conditions table for information that will need to be submitted for consideration. And then again, unacceptable listed is nortriptyline.
If you have suggestions for AME guide improvement, you can send those to ameguide@faa.gov. That email account address is specifically set up to receive suggestions for improvement to the guide. And I know in the 18 months I've been with Aerospace Med, I've seen quite a few changes to the guide and improvements. And then Dr. Wyrick, do you have anything to close us out with? That's pretty much it.
Yeah, just to say once again, thank you for participating as Aviation Medical Examiners. And we can't do it without you. Can't do it without you, as I've said in many, many seminars. And if you have additional comments, please don't hesitate to let us know about it. And, the first thing that, whenever we have a policy change, the first thing that Dr. Northrup asks is, how will this affect the aviation medical examiners? And, so you're always in the forefront, and we always appreciate your effort and your time. Thank you so much.
Thank you, Dr. Wyrick. Have a good evening. Thank you all for being here. We appreciate your time.